Good morning. Hi, I'm Donnabeth Sweetland, and of course this is Jackie MacKenzie.
Hello.
And we're very happy to be here to share our experience at the Woodstock General Hospital and in the Woodstock community proper with our flow spread strategy. What I truly believe about Woodstock General and the hospitals in Oxford County and throughout the Southwest is we're largely rural communities. And what comes with that is a culture of family and community and taking care of one another. It takes a very courageous group to sit back and say, okay, so how are we going to do this together? So the catalyst to the project is collaboration. And I truly believe that we're working hard at collaborating. So 2 acute care medical surgical units have so far been impacted by the flow spread strategy. This accounts for approximately 50 beds in the hospital. The average length of stay has decreased by approximately 1 day since the start of the flow in March 2009, and we celebrate that. I mean, that's huge. It has a huge impact in more ways than one. ALC, we have median scores of 21%. And so to drill that down a little bit, for the 1 unit, 5 out of 8 months our target has been met, and 29%, or on 3 East, 2 out of 4 months the target has been met. On the 4A unit, we had sustained a 19% ALC rate within target, which our target is 20%, until mid-December, when I think all of us probably across the whole Southwest experienced this. There was an upward trend. Increased demand during the holiday and outbreak season has clearly an impact on our situation. Bed turns overall have demonstrated an upward trend with a median score of 0.87, our target being 1. And so 5 out of 8 months on 4A, 0.3 to 0.8 off our target, and 0.995% for 3rd East. 1 out of 4 months we met the target, because we've only been going on that unit for about 4 months now, and 0.8 off the target. Time for admissions to order written for OT and PT, written orders. We've come from a 3.6 days to 1.9 days, or our target was 2, so we really need to celebrate that hard work. We decided to stop actually measuring that piece for a little while because, not unlike Tillsonburg, we're working on our admission triggers tool, and we feel that if we have that in place, that we'll be more consistent with our scores around admission orders for written orders for OT and PT. The sustainability score, another thing to celebrate. I think the first team I wasn't involved in Toronto, I think the score was something like 16. And we've, in November, moved that up to 41%, so I think that's wonderful. And we will, again, take the sustainability survey again now that we have a plan in place to talk about some of the areas that we can improve. I guess what I'll do is just comment on the top 4. The rest, we're continuing to drill down our plans on those. But again, the whiteboard with daily bullet rounds has gone out to 2 units. We're about to spread it to our third OB, and we look forward to that. I know that unit looks forward to it as well. Standardized risk triggers for referrals. There's been extensive work, and thank goodness St. Thomas did a lot of the work for us to begin with, and so thank you for that. But we're kind of taking out the wrinkles before we get started with that. And it's being trialed by different staff. Patient whiteboards, we're starting to talk about moving those out to clients' rooms, and what we will be doing is starting small and trialing it before we spread it to the whole unit. And then the discharge destination matrix is something that a smaller work group worked on. The Woodstock General CCAC case managers took on the discharge planner role starting in March or April, I think. And so we were able to sit down with our expert discharge planner who carried that role for many years, Stacia Bradshaw, and we really appreciate her feedback and teaching us kind of what she had done over the years. And we were able to put down, we kind of adapted one of the tools that came out of the Flow project, and we've got a sample at the back and some copies to take home with you. But what we did was we drilled it down to local retirement homes, long-term care homes, and actually what the eligibility criteria for those are as well. So we made it a little bit more customized to our communities.
One of the things we learned pretty quickly was that we needed to get ourselves organized, and we heard about this darn PDSA thing and wondered, well, how would we implement it? It meant, first of all, that Susan had to teach us, and then we had to teach our team and then get used to some of that jargon. But more importantly, what it really meant was focusing your attention on small things and trying to make small gains in what you're doing every day. So one change idea that we talked about was to engage both physicians and nursing attendants at bullet rounds. So to give you just a quick visual on what we do, we have 2 medical surgical units on the Flow project. We spend 15 minutes on each unit with allied health, discharge planning, physiotherapy, OT, etc., CCAC, a number of people there. We've asked primary nurses to come for 5 minutes so that we could ask them questions on their patients. So that attendance really wasn't what we hoped it would be. We wanted 100%, and as mentioned earlier, a lot of us are, sort of facing the same challenges, and one of those challenges was that nurses are very busy, codes happen, issues happen, so nursing often we're not able to attend. So that was the one thing. The other was trying to engage our physicians in trying to think about estimated date of discharge. That was quite challenging too. So what we did, we have approximately every 2 months rather large Flow meetings, about 15 people at least attend. Sometimes we have guests. And I have to acknowledge our team, one of the most enthusiastic groups I've ever met. And they each bought into this, not only as a group, but individually. So at these meetings, you really have to fight for airtime, actually. But what we decided to do on the physician side, and we can probably was to really think about how would we engage our physicians, how would we make it easy for them to start thinking about assigning an estimated date of discharge. We had tried initially with one of our surgeons who's very cooperative and said, if we put a little sticky on the doctor order sheet, will you just circle it every day? And that actually was our first PDSA cycle. It was successful for about 2 weeks, and then it fell short of our goal. What we then did was talk to the charge nurses and to the Flow team, got some ideas together, ultimately decided we would try a pilot with 3 physicians we thought would be more engaged perhaps than others that we could rely on. So we sent them a letter and asked them if they would trial a form, which we call a doctor's order board, that is kept in the nursing station and looks like this. So each doctor has a square, and they would put the patient down, and we write, do you want to discontinue antibiotics? Or any message we want to give them. So if the nurse isn't at the desk, the doctor then can see the message on the patient. We then put the colors, the famous, red, yellow, green, and we also put what that meant in terms of EDD. And we asked these 3 physicians, they were family physicians, if for 5 days they could go across and do this. And we sent them a memo and said, thank you very much in advance. The compliance was very good. I sent them each individually a thank you note after that. And then we have now gone hospital-wide. And those 3 physicians are actually still very engaged. So what we realized is that we need to send cards to our physicians to say thank you and encourage them to keep doing this. So this was what we've come up with. Our physician engagement has improved, I would say not remarkably, but our expectation is that after our last meeting, we would focus on a couple of physicians at a time and get them really involved in this, and hopefully over the course of the year hit and target all our physicians. To us, having physician engagement was crucial to the success of the Flow project because we all want to be on the same page.